So this was the topic given to me. I'm an orthopedic surgeon at Indus Hospital, Lahore. Um, I am a graduate of Allama Iqbal Medical College and did my training in the UK. And I'm recently an examiner of the Royal College of Surgeons, Edinburgh. So what is the constraint ladder of the TKR? This is what we were told when we were preparing for the exams. That uni, CR, PS, CCK, and hinge. But actually, in clinical practice, this is not how it works usually because there is an overlap. And I think this talk is really important for the newer surgeons, especially who are starting their career, and they will find that they will have patients who are in the gray area between two groups. And a place like Pakistan, where where the patients are paying for the implants, it's very important that you counsel them properly, and we'll come to that a bit more. So this is the uni, CRPS, and CCK, and then hinge. So obviously you don't need any sort of mediolateral support for an hinge. You get a lot of constraint in condylar constraint knee, CCK. CR is cruciate retaining, PS is posterior stabilized, and uni we all know. So complex, why is this important? This is a paper published from the Mayo Clinic in JBJS American, and they showed that the longevity of more constrained knees like a CCK or a hinge is much, much less as compared to a posterior stabilized or a CR knee. So if you've got an unstable knee and you have assessed it clinically during operation and you have found it to be unstable and you proceed with an expectant treatment, this is likely to not work. And even if the patient starts walking and they sort of start moving a little bit, the likely chance is that within a year, 2 years, or maximum 5 years, it will become edge loading and fail. I think it's very important. When I was leaving UK, there was a lot of stress on getting it right first time. And I think this is extremely important in arthroplasty. For trauma, it's different, and our trainees are mostly coming from trauma training background, and they think that, okay, well, if it doesn't work, we can always come back. In arthroplasty, your first chance is your best chance. And if you have planned and assessed the laxity and everything carefully, then it will be easier for the patient and the surgeon both. There are socioeconomic reasons. Patients are paying for their treatment in most instances. So if you are seeing them in clinic and you see this patient with a lax MCL and a bad-looking knee X-ray, if you tell them, well, I'm going to do a knee replacement in you, it may cost for the implant about 300,000, but it may also cost 1 million. They will straight away think that you don't know what you're doing. So it's very, you need a very careful discussion with the family explaining the percentage, but despite that, they tend to go for the surgeons who will say, well, primary should be fine. And nothing replaces a good physical exam. I've noticed that as we grow senior, we have got more and more patients, and we see and examine the patient less and less. A history, physical examination, investigations, and then a plan in consultation with patient is of paramount importance in all cases. So let's move on to the constraint ladder. So CR or PS knees. So this is a straightforward case which I did recently. She's got some osteophytes at the front. Well, from our perspective, this is straightforward. Yeah, not for a British perspective, probably. So she's got large osteophytes at the back, front. PFJ is completely gone. So I'm not going to try a CR in this patient and go for a PS. I was a CR surgeon trained by many, including some in this room. I still do CR sometimes, but I've gradually moved away to PS because of the severity of disease at the time they present. So she had this knee replacement, no issues, straightforward case. She was out, and this is vast majority of the workload you will see. But once we move on to a bit higher sort of category, like in this case, I think I would go for a PS. But this is not uncommon to see this type of x-rays. This is a lady I did recently. So she has got this ossicle in the MCL. You don't know whether this is going to be okay when you take this when you clear the osteophytes. It's quite subluxed laterally as well. I did the right side. So in these situations, you are thinking, will I be okay with the primary implant? The chances are yes. But the question is, what do you tell the patient? That are you going to have an LCCK on standby? If you're going to have an CCK on standby, are you going to tell the patient that they're going to be paying more than twice for an implant? So that is what makes it tricky. And if you examine it carefully, like I discussed this case with Richard before I went, and he said, oh, you'll be fine. All you need to do is, if it's clinically stable, the MCL, it's going to be stable afterwards. And this patient had and we'll come back to this case again. So we are in the constraint ladder, and let's move on to the CCK and hinge level. Now, you've got cases where you are struggling, they are no longer in between, and they are unstable. So in these cases, no matter what you do in the non-challenging cases, you are okay usually with a primary implant. So the cost we have discussed is important. How do you counsel the patient? You need to have equipment. We don't have the mediolateral support or the CCK implants available. We have to call them from another city. It requires a lot of organization, patient counseling, as we have discussed. So this is the challenge in the cases which are landing between the PS and the CCK. And unfortunately, we see quite a few of them. And then the technical expertise, whether you have the expertise to do a CCK. If this is something which you are a novice to, then I suggest you refer this patient to somebody more experienced, because you always go with a plan B, but you need to be mindful of the fact that you have the ability to execute plan B. So this is another case of mine. I did the right total knee replacement. It was, again, a very osteoporotic, difficult case. Quite subluxation. There's not enough in the, the x-ray is not very clear, but the patella is too low. The slope is, there's a large osteophyte, and PCL is completely gone. So this case, she had an injury about 20 years ago, has been walking on it for the last 20 years. So we went with a primary implant, but the CCK on standby. Again, clinical examination was okay, MCL was intact, and we managed to execute the operative plan reasonably well. So this is the case we just discussed. We are quite used to doing these cases now over here in Pakistan, unfortunately, but most cases and simple PS knee will usually suffice. But what about these cases? If you have got such case, this is not my case, this is from the internet, this picture. If you've got an MCL on weight-bearing view like this, or a stress view, some people do stress views, I don't, because I think the amount of stress the knee is going to go through is while they're standing or walking. So this is what I just do a standing view, but this is a stress view done, and the surgeon decided to do a constraint implant. So we have got three options available over here. We've got TC3, LCCK, and SSK available over here. And they can be used both as a primary case or in revision cases as well, depending upon the pathology. So if we move up the ladder, CCK and hinge, this is a case, unfortunately, I can't get her post-op x-ray. This is a case I assisted in when I was doing my arthroplasty fellowship in Liverpool. She had got fibular hemimelia, and she was referred for an amputation, but had a hinge and did very well. Similarly, if you want to do a hinge, these type of cases, GCT, or you can use a megaprosthesis. This is the last line of defense. So after this, you don't have much option left. This is a similar case of mine with a GCT, and we have done a megaprosthesis as well. Thank you very much.